Good afternoon, everyone.
Good afternoon.
Yeah, thank you for joining us today on another eco session for the southern region of Africa CDC. My name is Ezinewekwe, and today, agenda, like we shared, we're going to be talking about the roles of community healthcare workers in COVID-19 response on the continent, and we'll be looking at what's going on in Zimbabwe. And so before we proceed, as usual, echo etiquettes. To mute yourself when you're not speaking. You can use the chat function. If while the presentation is going on, you have any question, you can drop it there, we'll get back to you. Try to label yourself with your name and the country you are from or representing. I think that's just basically it. We already have about 18 people on the call, which is very impressive. Thank you for joining us early. We can just do a quick round of introduction so that we just wait for more people to join. So we'll start with us here at the RCC. Dr. Lul, could you introduce yourself, please? Dr. Lul? Okay, he's still muted. Dr. Lul is the regional coordinator for the RCC. Here with me is another colleague. You can introduce yourself.
Good afternoon, colleagues. My name is Chika Okanedo. I'm an EPID analyst working at the Surveillance and Intelligence Unit. Thank you.
Okay, my name is Ezinewekwe, Public Health Officer with the Regional Collaboratory Center. There is a Mabel Mfula. Mabel, can you tell us which country you're with and what you do?
Mabel Fila, I'm a community health officer, Ministry of Health, Zambia.
Okay. Thank you very much, Mabel. There is Patrick Sakobita. Okay. There is Dr. Moekets.
Afternoon, it's Moketsi Mudisenyane from the Ministry of Health South Africa, responsible for contact tracing. Over.
Okay, thank you so much, South Africa, for joining us today. We have, let me see the list. We have Melody.
Good afternoon, everyone. I'm Melody Kalombo from Community Health, Ministry of Health, Zambia.
Oh, great. We have quite a lot of people from Zambia. There is also a Gerald who has already labeled himself as Zambia.
No, that's Zimba.
Oh, Zimba. Oh, sorry. Where are you from, Gerald?
Like you said, I'm from Zambia. I'm with Melody, we work in the same office. So I'm with community health.
Okay, great, thank you. There is Francis Handuka. He's already labeled Zambia as well. I think that's one of our field EPIs for the COVID response. So move to Iyalo Waningage. I'm sorry if I didn't pronounce that well.
No, you pronounce it well.
Sorry, you're breaking.
Yes. My name is Iyalo. I'm heading Epidemiology Division, Ministry of Health, Namibia.
Okay, great. Thank you.
Good afternoon, colleagues. So far in Zambia.
Chica. Okay, then we have, there is Mazula Kapina. Who I know is from Zambia. Maybe to just save time, those I can identify, I can just do a quick round of introduction for those I can identify, and then have the other new people who haven't been around introduce themselves. So we have Mazula Kapina, who I know is with the ZMPHR in Zambia. There is Nelia Langa, who is one of our COVID-19 rapid responders in Zambia. Olivia Nakwafila is also a COVID-19 responder, but in Namibia. Patrick Sakobita is a COVID-19 responder in Zambia. There is Dr. Paul Zulu, who is with the Public Health Institutes in Zambia. There is Dr. Portia Manangazira, who is with the Ministry of Health in Zimbabwe and will be presenting today. Then there is Nji Kaura, who is with the Ministry of Health, Namibia. Vivian, I know, is with AMREF in Zambia. They are coordinating the Community Healthcare Workers Initiative in Zambia. There is also Dr. Watipaso, who is from the Ministry of Health in Malawi. So these are those I know. So I'll just call on, there is Sam Theka, if you can introduce yourself and the country you're coming from.
Good day, colleagues. My name is Sam Theka from National Department of Health on contract tracing in South Africa. Thanks.
Oh, great, South Africa. Thank you very much. And there is a Vuskovic Chanda.
Yes, good afternoon, everyone. My name is Chanda Vuskovic. I'm a community health worker from Zambian Ministry of Health. Thanks.
Great. Thank you very much for joining us today. Is there anyone else then? Okay, there is Dr. Owen Mosopole from the Ministry of Health in Malawi has also joined. Another of my colleague, Dr. Bakare, has also joined. Then there's Kogmotso Breeds. Could you introduce yourself and the country you're from, please?
Hi, I'm Komodo Brez, National Department of Health, South Africa.
Great, we have a good representation from South Africa today. And Etha Halundulu has joined us. Etha, I don't remember which country you are from. She's dropped again. Okay, anyway, so as more people join, we can actually kick off the presentation for today. I don't know if Dr. Lul, are you able to unmute and just give us some quick opening remarks? I think you might be having some connection issues.
Hello, can you hear me?
Yes, we can hear you now. Initially, we couldn't hear you. Just a quick opening remarks, and we can go into the topic for today. Great. Dr. Lul?
Okay. Well, good afternoon, ladies and gentlemen on call. My name is Dr. Lurik on behalf of Southern Africa RCC. First, I would like to seize this opportunity to express my sincere gratitude to all of you for taking time to as informative, exciting, and for sharing the relevant information that we truly need. And one of the agenda items for today, ECO, is very, very, very important. You know, our colleague, Dr. Linda, she's going to give us a very, very brief presentation on the role of healthcare workers in context of the COVID-19. As all of us have been aware, that COVID-19 has been devastating, not only just to the Southern Africans, not only just to the fighting it need to be very, very creative and using the community health workers experience that well been documented. They are filling some of the gaps that we truly, truly need. And one of the pivotal issues that we need to find a way, especially in those countries that was a very, very gaps in healthcare systems. The role that has been played by community healthcare workers is extraordinary, and especially when you come to the contact tracings in responding to COVID-19, it has been identified in many countries like it's a game changer for the interrupting of the spread of the virus. So let's seize this opportunity. Let's see what works, what did not work, what are the challenges that we together can be able to work with the member states to try to address those gaps. But I want to assure you that from Southern Africa RCC, we will do whatever it takes to make sure this eco platform is live into its objective and its goal that it was created to share the relevant information among member states to increase the coordinations and also working together. So I thank you once again, and please stay till to the end. Back to you, Esme. Thank you.
You're welcome, sir. So thank you everyone for joining us. We're going to really kick off. We have quite a lot to discuss today, and we'll start with our usual very brief overview of the numbers, the epidemiological situation of the pandemic across the continent. So as at today, the 16th, globally, those are the figures. we have 71 million confirmed cases and more than 1.6 people have died, and the CFR remains at 2.3. And if you look at the epi curve, it's when we talk about the resurgence, the second wave, you can really see that it's happening. So on all the regions, even in Africa, you could see that we're having cases rising. It's very graphic when you look at the graph. So coming down to the situation in Africa, we can also see now when we talk about that second wave, that it's very glaring. So we have more than 2.4 million cases and 57,000 people have died. CRFR is slightly higher, 2.4% across the continent. And we have 85% people who are recovered. So we can see that graphically that there was a dip and now it's rising, and you can see how it's broken down to the different regions, and the southern region, yes, accounts for quite a significant number of the cases, but that's mostly due to, well, not really mostly, but South Africa having a huge portion of the cases. So looking at the tests conducted across the continent, more than 2.3 million tests have been conducted from February up till 13th December, and 23.9 million tests have been conducted. And the positivity rate is at 10%. And yeah, so just briefly to just give you an overview of the situation across the continent, so that we can keep in mind why it's necessary for us to, we can't really push away and stop talking about COVID-19, because like we've seen from the figures, the numbers are rising again. And if we are tired, we need to buckle up and realize that this is not, it's not over yet. And that's why the conversation we're going to have today is very important, looking at the role that community healthcare workers is playing in the response. And so I want to introduce our colleagues from the headquarters. Over to you. I think Thade will be representing Dr. Herlinda for the presentation. So over to you, Thade. You can introduce yourself, and do you wish I share your slide, or do you have your slides to share?
Yeah, I have my slides to share. Good afternoon.
Over to you. Introduce yourself and we'll have it.
Okay. Yeah, thank you. Thank you, Zineth. Good afternoon, everyone. My name is Tadeni Itongira. I'm a public health technical officer within the Division of Disease Control and Prevention at Africa CDC headquarters. And that community health part of the coordinating team at the headquarters. So I'm really glad to be on this ECHO platform to be able to share some information as requested by Ezini. Ezini, can you hear me?
Yes, I can hear you, Thade.
Okay, yeah, okay, thank you so much. So as Ezini was saying, as all of you know, the Africa CDC leadership, of course, African Union Commission through Africa CDC, they have launched PACT, which is a partnership to accelerate COVID-19 testing in Africa. Of course, PACT has 3 components, which are, first of all, to be able to accelerate COVID-19 testing capacity in Africa. Just Ezine has shared the updated numbers of that we have been able to conduct in Africa, 23 million plus. Of course, the second part of the PACT initiatives to be able to deploy community health focus for the contact tracing, active search of cases, but also community engagement. And of course, the last component of PACT is to be able to treat confirmed cases. So we might think, what are now the goals of the parts. First of all, initially when it was launched, the goal was to conduct 1 million tests in 1 month, and then be able to conduct 10 million tests in 4 months. This goal was really met. And then the second goal was to establish Africa-wide pool procurement platform. This is already established. Also, the third is to establish Africa-wide storage and distribution hubs. This is also established. And to be able to deploy 1 million community health workers, yeah, this we have already embarked in this journey, and I'm going to provide the updated numbers with regard to deployment of community health workers. And then last, it was to be able to standardize and deploy new technology for surveillance to help European economies. So specifically now to the second objective, which is to deploy community focus for contact tracing, active case search, and community engagement. So of course, at the first or in the first period, it was our target was to be able to deploy 1,100 community focus on, of course, for COVID response. This we're targeting to be able to deploy these 100,000 community focus in 12 months. So, for like any member state, you know, following the launch of PACT, Africa CDC has shared a note verbal, both in French and English, to all member states requesting or informing members that we have this this plan and we have this support to member states. So we were requesting that any member state that is interested or which would like to have such kind of support to notify or to send an official request. So, so for all member states, the support was to, of course, to support the training of 1,000 community health workers in total on testing, tracing, and the treatment for COVID response, but also ensure sufficient PPEs they are available for those community health workers that we were deploying. And then for select countries committed to scaling up community health workers program now, it is to be able to mobilize Catholic resources for government to fund the first 6-12 months of new or community focus, of course, for compensation, for transport, communication, and also supportive supervision. Also, this is, of course, in case that there is a commitment to ongoing domestic financing with the national budget. Also, it was to be able to scale up training support to 1,000 community focus to 1 million to address future public health pandemic. In fact, we're going to talk about this where we are now looking at how we can even transition from COVID-19 related activities to health system strengthening activities. We are going to talk about it when we arrive on where we launched the Community Health Focus Technical Working Group. Now, when specifically what are our targets, what is the plan and the fund, what is the implementation plan also, or how do we monitor and of course get lessons from the experience. Now, the target is the initial prioritization, of course, based on country demand and the implementation plan. Here I talked that when we sent the note verbal, of course, we are expecting a country to make a formal request. And of course, based on that formal request, then the process of getting deployed community focus in that country can start. Also, when it comes to plan and fund, of course, we, after that initial contact, member states, of course, has to develop a plan or a funding request. And of course, this is done with Africa CDC personnel at the headquarters, either Dr. Linda or me, where we guide, because under this project, there are some items that are not covered. And then when it comes to implementation, as I said, of course, the implementation is done by member states, but also together with an implementing partner. So here, Africa CDC, of course, provides some guidance on deliverables, reporting templates, and of course, funding accountability. So here, an MOU or a Memorandum of Understanding is signed between Africa CDC, AFNet, and the implementing partner. And also member states and the implementing partners, of course, they do train community health workers, of course, after the initial training of trainers, which is conducted by Africa CDC. And then when it comes to monitoring and evaluation, it's of course the coordinator, the national coordinator, together with the supervisor who conduct the progress, who monitor the progress in country, of course, report on indicators, and of course, Ezini, can you please remove this? I've seen that you have done it. Okay, yes. So of course, it's Africa CDC, of course, we track the overall progress on the PACT initiative implementation. And of course, we are expecting that the member states can share like some experiences that we are going even to hear from the experience of Zimbabwe today, so that we can, of course, improve where we are not doing good. But also here, member states soon will be expected to be invited in our technical working group, especially in the different subcommittees, just to share experiences and lesson learned during the implementation. Then, when it comes to progress today, I initially told you that we are looking at deploying 100,000 community focus in a period of 12 months. So as of today, Africa CDC has been able to support almost 15,000 community health workers across 20 member states for COVID-19 response. And here, 32 out of 55 member states, they are already engaged in this initiative. And they are actively pushing partnership with the remaining 23 member states that need to be still engaged. Here I can say that for the Central Africa region, almost all the countries have been contacted, but 7 out of 9, they have already responded. We have already initiated the program, and soon 7 out of 9 they will be having or they will be implementing PACT initiative. So I'm not sure for other regions, but I know that all the region were trying to contact countries specifically so that this program can be implemented. So there are 2 engagement models. First of all, there is a direct government implementation, or there is implementing partners. For instance, in Central African Republic, Red Cross also in Republic of Congo. We are using like AFNet in using AFNet, but also different local NGOs. Now, what is Africa CDC next milestone in terms to community health focus? Of course, the next milestone is to scale up support in achieving the 100,000 community focus deployment within 12 months, and but also build capacity for 1 million plus community focus, of course, contributing to health system strengthening. So we are going, of course, to to reinforce engagement with countries and also increase numbers of community focus already supported, and also broaden scope of support. Example, supportive supervision. Here, I had to highlight that during the first coordination call we had with different coordinators, there were some challenges with regard to supervision visits. So this is one area that we are going to improve in. But also we are going to have new engagement in the remaining 23 countries to co-design the deployment. But also when it comes to continental operation, I have talked about also already a technical working group that we have already initiated. Luckily, the co-chair of the technical working group is here with us. That's Dr. Pocha, who is going to share with us. I'm sure she will talk about a little bit on the community focused technical working group. So, but also we are going to develop guidance on, of course, on community focused sustainability and financing. We are also going to conduct national community focus program situational analysis and, of course, partners mapping, but also preparing for future community focused roles in rapid testing, vaccine, but also build a resilient health system. Now, when it comes to committee focused technical working group that I just mentioned, it's a committee of technical experts in committee for program and health system strengthening. And this technical working group is led by member states and of course comprised of subcommittees with specific expertise that we provide technical and operational input that of course will guide the community focus program implementation. Here, different subgroup include finance and sustainability. It includes partners and member states engagement. It includes monitoring the evaluation and the research. It includes also policy and guidance document development. Now, community focused technical working group is also structured in line with the model established under the AFTCO, which is the Africa Task Force on Coronavirus Preparedness and Response. So this, I'm sure all of you, some maybe who are part of the coordinating, have seen a survey that we are conducting, and of course, and partners mapping, just to be able to determine the national community focus program status for targeted support, and also for effective coordination of partners implementing community focus program in the continent. Now, when it comes to deployment for the region, Southern Africa region, so we have almost 7 countries who have already enrolled, of course 7 out of 10, that's almost 70%. And we have also 3 who are not yet engaged, that's 30%. Deployment in only 3 countries, that's Malawi, Zambia, and Zimbabwe. And we have 1 which is on training stage, that's South Africa. And we have 1 which is on planning stage. Sorry, the other one was on training stage. So the country which is on a planning stage is Eswatini, and there is 2 who are on delayed response, that's Mozambique and Lesotho. So I just talked about, we were able to receive it from Zimbabwe and Eswatini, so we are expecting for other countries to fill that survey so that really you can have that, that information. I've talked about why we are requesting those information on a survey. So what are now the next step? the next step is, of course, to invite remaining countries to enroll in the initiative, but also support member states to establish or expand, but also strengthen national community focus program. Also is to be able to map community focus partners in the continent, conduct national community program inventory in the continent, of course, call for member states and partners to join community health worker technical working group. So here I have to highlight that we normally we are having a weekly technical working group. Of course, this was decided because we had many items to discuss on, but we are, I think, the co-chair, I don't know if she will have time to talk about it. We are going to, of course, to have a bi-weekly, not a bi-weekly, but once in 2 weeks a call. So it really depends on the decision from participant. So really I'm calling upon member state representative from the Southern Africa ICC to join us in this technical working group. It's really a very good platform where we can have information sharing, but also have some more expertise shared, of course, and some orientation on how we can really conduct and this program, or this community focus program. So this was my presentation on community focus program. So I'm really here around for a short term, a short period, because I will be preparing for the technical working group. I will be happy to receive some questions. Over to you, Ezine.
Thank you so much, Tade, for a very detailed presentation. I'm sure some of us are hearing about this for the first time, and some of us have already known this, some have seen emails. So this is just to get us all on board so that when we start talking about experiences from countries, we have a background and we understand where they're coming from. So like you said, if you have any questions, some countries have been sort of called out today, where there are 3 countries in our region that we haven't heard, we've written and all that and no response. So if representation from those countries are here, you can give us advice as to how to better engage with your country. Angola, Botswana, and Namibia, we have no response from them at all. So if you're online, you can tell us or give us advice on how to engage better. And he's here for questions. If you have any questions, any comments, you can share. I already have one from South Africa. They're already on board with us. And Dr. Moketsi says it's very important that before signing of MOU with implementing partner, that there is an approval from the member states so that the implementing partner understands the national plan, monitoring plan, and reporting systems. It's very, very important. This is a very, very important point. Thank you so much, South Africa, for that.
May I comment on this?
Someone has hand is up. Let the person talk and then you can give feedback.
Okay, okay.
Mrs. Kara, you can unmute yourself and talk.
Excuse me. Good afternoon, colleagues.
Good
afternoon, Ezzy. It's been a long time since I was on this platform. I'm very happy to join today. Yes, I just wanted to say that this is a very good initiative. And like you say, some of us, it's the first time to hear about this, and I'm one of them. And for me, it sounds really like a very good initiative, especially now looking at the COVID picture in the continent. So, but I've got 2 questions. My first question is, in the presentation that they were talking about, the presenter was talking about they are busy pursuing partnership. Is it partnership with the implementing teams or partnership also now with the countries? And then also they say they invite countries to enroll in an initiative, which is a good thing. Now my question is, was there any formal communication sent to Namibia specific? If it is so, to whom was it sent? Where can I follow it up? And then my second question is, I don't know whether it was answered already in the chat platform, because I did not get time to read. I was now listening to you because you were inviting me to talk. Let's say, for an example, in Namibia, we don't have AMREF, we don't have the other, but we do have Namibia Red Cross Society. So which means maybe in our case, in the case of Namibia, we can make use of the Red Cross. Does it mean that before we enroll in this initiative as a country, there should be memorandum of understanding between Namibia Red Cross Society and Ministry of Health, or how did I understand it? So that's my two questions. And then also the Community Health Workers Technical Working Group, who's taking, when does it take place? I'm sure it's a meeting. How do they communicate, and who should take part? Is it only the community health workers themselves, or also maybe members of the Ministry of Health who have ensured that health workers technical working group? Thank you so much. That's all questions that I'm hearing.
Okay, thanks a lot. So over to you, Tade. You can respond to these and the comments you had. And if anybody has any question, please put it in the chat so that after his response, we can take the experience from Zimbabwe and then get back to answering questions. Over to you, Tade.
Thank you so much, Ezine, and thank you for really the good questions. Let me first start by the comment from Dr. Moketsi. She says it's very, very important that before signing MOU with implementing partner, there was approval from member states so that implementing partner understand national plan, monitoring plan, and reporting system. Well, first of all, when we contact countries, we address ourselves to ministries of health, and everything, like when it comes to, first of all, the Ministry of Health has to submit a concept note. In that concept note, there might be like some highlights where the Red Cross, because we cannot, of course, be able to support like community focus for the whole country. So we need some targets, like where the hotspots of the COVID-19. So there might be some highlight, or some like district must be highlighted where they are going to use the community workers. So, and after the concept note, then we have to have an engagement call with the country, the ministers of health, where of course we have to highlight like the package of the support that Africa CDC will be providing to a country, but also what are our what are the responsibility of Africa CDC, and what are the responsibility from of the member states. And then, of course, why are we talking about a partner in this case? You know, the model in which Africa CDC function is the same model of the African Union, because Africa CDC is an institution of the African Union. And as all of you know, African Union is made of member states. So Africa CDC or African Union cannot hold accountable to a member state. That's why, for issue of accountability purposes, we need an implementing partner. And this implementing partner is not like something that, or someone that Africa CDC will dream about. No, no, no. It's the Ministry of Health who will now designate which implementing partner in country they would like to work with. Of course, the implementing partner will come and implement the agreed upon objective between Africa CDC and MOU and the Ministry of Health. So it's not something that the implementing partner will come like bring new. No, no, no. It has to be something that was approved by between Ministries of Health and Africa CDC. But also when it comes to implementation implementation model, the member state has to have a national coordinator. The national coordinator, either one or two, they work in close collaboration with the implementing partner, which means like the implementing partner will not bring anything new from like the approved activities or the approved budget. So even when it comes to reporting, the implementing partner, they have to agree upon. The report has first to be approved by the member state before it can be shared. So this is the model that we're using. Anything has to be approved by the country first. Then here he said that the MAU, or if I can call MOU or the contract, has to be they have to have an approval from the member state. Of course, the MOU or the contract, the content of that MOU or the content of that contract is shared pre or before to a member state. The member state has to see what is what is the content of that contract or that MOU, and then after that, the contract has to be issued by AFNET. So that's with regard to that comment. And then there is another colleague who asked about formal communication. Yes, the formal communication was shared to all embassies in Africa cities. As all of you know, we communicate with member states through note verbal. So we share a note verbal. Our agency send it to embassies in Africa, in Addis Ababa. So all the embassies of the member states in Addis Ababa, and then those embassies, they do share with their foreign affairs ministries, and then foreign affairs ministry, we share with the respective ministry targeted. So I'm hoping that maybe the communication was not has not been able to reach to your ministry, but Ezini here, I think she will share with you that a note verbal that was sent. It was back in July. So if Ezini doesn't have that note verbal, I can still share with her so that she can share with you. Now, when it comes to partners, of course, there is no specific partners. I have already talked about it. It's the member states to identify which partner they wish to work with in this implementation of community health forecast. Now, when it comes to community health forecast technical working group, yes, we do have a meeting on every Wednesday, of course, by 4 at this time, or East African time. We have a meeting, and initially we have requested that any member state, of course, the coordinators of community forecast should be part of this technical working group. And really, it's a core, or it's a reminder. I'm really, I will be grateful, or we'll be grateful to have a member state representative on this technical working group. It will be really an honor for us. How the meeting is conducted on Zoom, personally, I will be sharing the meeting invite. So I can share with Ezine, who is to the RCC, and she can be able to share with any person who is interested in participating in this technical working group. So I think I was able to respond to some of your questions. So because of interest of time, let me allow the Zimbabwe representative maybe to share their experience. Over to you, Ezine.
Oh, thank you very much, Dade, for responding. She has another question in the chat. You can quickly answer that. She had dropped something. So we really like to hear, even if it's those, I think we have representation from Eswatini, Mozambique, Lesotho online. If you can drop on the chat who we can write to, who you know in your country, will be able to push for this in your country. You can drop the contact of the person via chat, and we can reach out to your country to get on board. So I'm going to hand over to Dr. Portia, who will introduce herself. She is a co-chairperson for the Community Healthcare Workers TWG, as well as I think coordinates it in Zimbabwe. Over to you, Dr. Portia.
Okay, so thank you very much for arranging this information sharing platform. And good afternoon, colleagues who are online. I have the privilege of sharing our Zimbabwean experience regarding the deployment of community-based volunteers to fight the COVID-19 crisis in Zimbabwe. So I'll give an update. We started way back in July, and to date we have managed to deploy 1,000 volunteer community workers. Let me just switch off the video so that my network may be a bit wavering. So can I, and thank you Azin for agreeing to screen share my slides. Can I have the next slide? Okay, so our program looked at the COVID-19 challenge within Zimbabwe. Initially, of course, it was coming from outside. We confirmed our first case on the 20th of March, and we saw a, reporting, but with an increase starting in May and peaking in July, and then receding. Our graph then receded in August and September, but as of November, we have noted an increase in the number of cases. So in terms of the volunteer community worker deployment, we were looking to study the local transmission, but also the importation patterns within the country, and concentrate on areas that needed interventions the most. We also were acknowledging the gravity of the pandemic and the intensity of measures to address the crisis. I've been practicing public health in Zimbabwe more than 15 years. We never saw a lockdown. We never used the quarantine as a measure. So I was really worried how people were coping all the way to the businesses in terms of the closures of borders. So, and also how do we deal with an infection that spreads so rapidly? And yet our population in Zimbabwe has been very mobile. I'm sure you have Zimbabweans in all of your countries. So that was my major concern. And we looked to check with the communities on how they are coping, given that there is no cure and no vaccine. And in June, when the PACT initiative was launched at Africa CDC, we immediately got the information, and I really want to appreciate all the work that the colleagues at Africa CDC have been doing. So, as I said, we have seen a rise in cases. As of now, we have more than 11,000 cases and 310 deaths as of today. We have been conducting testing in terms of the PCR and rapid tests, but with various indications and interpretations. And again, we also needed the community to come in on board and support. So in terms of the key sensitization activities that we conducted from the program inception in July up to now, the volunteer community workers have been subjected to a 2-day training. And then after that, they have to report to us on a weekly basis on agreed indicators between us and the Africa CDC. But furthermore, we have also been interested in giving them more space to report in terms of sending us pictures and also narrative reports at least once a month. So we've been gathering as much information as possible just so that we appreciate more the pandemic, but also how the Zimbabwean population is coping. So they've been doing the community dialogues, including going door to door within their communities, and also observance of how the population is adhering to the preventive measures. They've also been assisting screening at public transport systems, the various conveyances, as well as shops, supermarkets, but also the markets where people converge and sell or buy stuff. Also checking and correcting behaviors, particularly social distancing, the proper use of mouths, masks, as well as acknowledging. It's always amazing how people feel encouraged when you give them a compliment to say you are doing things correctly, but also it's important to correct those that just hang the mask around the neck just to show police that they are complying rather than using it to protect themselves. The community volunteers have also met with local leadership structures, including the church leaders and the village heads. We trained in venues around the country when we got resources to conduct provincial trainings. So in every province we went to, we tried to look out for the local artists so that they can then continue the messaging in terms of the drama, poetry, and music. And that also helped a lot. And it also allowed us to make use of this community outreach program to look for champions at national, but also at sub-national level. And the volunteer community workers have been instrumental in continuing the awareness at gatherings. You know, people still have to bury, they have to do weddings and parties, and they've been very instrumental at ensuring that there's compliance on preventive measures. We do have a couple of volunteer community workers that have been going around supermarkets, and the management have acknowledged their work to such an extent that they give them the loud hailers so that they are continually talking to the people shopping in their areas to keep those safe. They've also understood, in terms of the community component of IPC, the importance of thorough and correct hand washing, and they've been demonstrating the hand washing as they go about their duties. Next slide. So in terms of the accomplishments, we have reached almost 10,000 people now through health education and information dissemination, tracked the contacts and provided them with information and advice of what to do, and then managed to identify and refer more than 2,000 suspected cases to local rapid response teams. In fact, as we trained the community volunteers, we established linkages with the local rapid response team so that in terms of the trace, the PACT initiative, once people have been contacted and traced, they are referred appropriately, and then the health system takes care of them. We also monitored and supported 307 COVID cases in home isolation. I think we all appreciate that almost 80% of SARS-CoV-2 positive patients, or even the mild COVID-19 patients, will be seen within the community. And even those that are discharged from isolation come back to the community. So it was very important to ensure that there is knowledge of how to manage patients, address issues of stigma by giving information on how to correctly home isolate or home quarantine, and ensure that there are no secondary infection arising within the home. We also established community-based committees for surveillance and risk communication at village level. This has been in conjunction with our risk surveillance pillar of the national response. So the next few slides are just to share in pictures some of the volunteer community workers at work within their communities. The first slide to picture to the left there shows, I think it's a bit exaggerated social distancing. This was at a funeral recently in Bulawayo, and Bulawayo has been our hotspot with high numbers of SARS-CoV-2 cases, but also deaths. So this trained volunteer worker was addressing the gathering, but you would think you would need a hailer, the distance is just too much, but I'm sure they were understanding each other. But that's how well they've understood the issue of social distancing. And the picture on the right shows a priest at a, okay, sorry, so I think I've got the, okay, so that's the next slide. No, that's okay. So the other two show temperature checks. And the picture on the right, the volunteer worker does not speak. He had throat cancer. But it's amazing how he's been going around, and you can see by his narrative reports and pictures that he's actually making a difference in his community. He's a retired prison officer, so he commands a bit of authority still, and he's been able to impart knowledge despite his inability to speak. And then the next pictures show public space awareness by the community health workers. This is at our biggest market in Bare, in Harare, where a volunteer worker was talking to some of the vendors, but also passers-by. And I talked about the loud dealers within a supermarket. That's the picture on the right. And the next picture shows the COVID awareness in schools by our volunteer community workers. Next slide, please. So that's an early childhood teacher, but she was not limiting herself to the early childhood learners. These are primary school learners, and she was addressing them in Mutare. And then the next one was in the Midlands, again addressing learners, primary school children. Next one. And on that one, they are showing how to do hand washing correctly. And it's because we embedded IPC in the community-based worker training program, following support from Africa CDC, again, our IPC colleagues, that allowed us from the nursing into the community for reasons that I've already mentioned. Next slide. And the next one shows the awareness within the churches. We included some of the church, various church groups, because we know that the religious or clergy are very influential in our communities. So if you give them information, when they speak to their followers, the message is taken better. Sometimes, there's this skepticism about us in government. So I think we realized quite a lot of mileage within this is the Methodist church, those ladies in red. And then we have the African churches who worship in the open, and sometimes with no toilet or hand washing facilities. But you can see they've already been assisted to put a bucket there for hand washing. They are socially distancing and they are wearing masks. So the next few slides will just celebrate some of our successes, but also highlight some of the gaps and challenges in terms of understanding of SARS-CoV-2 and COVID-19, which remains low, and sometimes it impacts negatively on adherence to preventive or protective measures. People are still reluctant to limit unnecessary movement. Sometimes they don't practice social distancing. You move away from somebody and they move even closer to you. And the hand washing is still not quite practiced as much as we would want to. We've been in schools where there is few or maybe no even observable hand washing stations. And the issue of masking, there's a lot of excuses that are given, it's too hot and so on. So we would want people to adhere to that. In some places, communities are assuming that COVID-19 no longer exists. And some don't even believe in it. They think it's a problem of those who fly in aeroplanes and so on. But here in Zimbabwe, we've also experienced macroeconomic challenges, which have limited infrastructure. If you want social distancing within a school, you're going to need construction of new classrooms. And that's not quite, it's not been possible in the 6 months of the extended closure of schools. The few public conveyances, and then we still have quite a lot of more rather than formal sector, and that gives challenges in terms of adherence to some of the protective measures. We also have not quite had adequate PPEs in terms of the masks, but also sanitizers. Despite considerable local production, they remain inadequate. Water shortages, and we saw a challenge in Bulawayo when you want to tell the community to wash their hands, to be clean, but the water is just not there. So it then raises challenges of getting your messages across and having the right behaviors when that kind of situation prevails. Availability and cost of sanitizers, these are still way out, and it's only few people that can afford them, so they expect somebody to provide. There's also the issue of reuse of face masks and poor waste management. And children in schools have not been wearing masks, and sometimes they exchange them. I mentioned the issue of social distancing. However, we have realized successes, and we really appreciate the resources and opportunity, because we saw massive transformation of ordinary community members. I think when they got to wear the green jacket, a t-shirt, some identifiable, they really felt good about themselves, especially after the information during the training. In fact, some of the feedback we were getting was, when I talked to people, they said, for the first time, somebody has told me what I can understand about this COVID thing. So I think that interpersonal communication that has been afforded by this pre-deployment training and then deployment of the community volunteers is really appreciated. Yes, the flyer can be sent, the information can be heard on the national television or even the local radio stations, but it makes a difference when somebody is there and they can answer questions, and those questions that they can't answer, they can still say, I'll come back to you, because we have established a chain where they can get more information or relate to the health facilities close to them. So the training of 1,000 volunteers, we managed to do it, and there's not been a single person who came back to us to say, I got COVID-19 from your training. So I think that's a success. We must have done things right there. The community workers have demonstrated ability to identify and refer suspected cases to rapid response teams. And we are also using that conduit to now strengthen further our rapid response teams. And then we are using a situation report, which has been useful in making communities change their attitude towards COVID-19. Because if they say there are no cases, you can give them the seat rep that gives indication of where the cases have been reported, where and who is affected. And we managed to get to the communities through these volunteer communities. So we also managed to have the volunteer community workers assist in ensuring that there is supervision of burials within the communities. Because once there is a death within the communities, they will sniff it out and quickly inform the local health facility. So I'll just end by posing a few questions that have been posed to us by communities. Is this pandemic going to end? And why did the government lift the lockdown while the situation needs more attention? Why is government allowing borders to open while cases are going up? And are there any solutions to control the disease or any chances of getting a cure? So I would like to thank you, but also just to thank again the support from Africa CDC and our agency that is managing the funds here is AFENET. But we have also managed to use this platform to attract additional funding from the Civic Forum on Human Development, who are also supported by the Swedish government and the IOM. And for that reason, we were able to give the volunteer community workers the package that you see in those bags: 2 t-shirts, a jacket, a non-contact thermometer, a phone for reporting, and a box of gloves so that they can assist those that are in home isolation within their community. And we also linked up with the experts that had been earlier deployed to support, and that's the picture you see on the left. So we do have the volunteer experts deployed by Africa CDC, and they've also been instrumental in buttressing support for the volunteer community worker program. So I'll pause there and thank you very much for the opportunity to talk to you about our program and welcome any further suggestions to improve. And I'm also happy to take questions. Thank you so much to Dr. Linda and Tade and the team. Over back to you, Madam Chair.
Thank you so much, Dr. Portia. You have really been, I was telling someone that to me, Zimbabwe has really been very, very, very proactive when it comes to these sort of initiatives. And that's why we thought we hear from you and how far it's going as an encouragement to other member states. As we are hoping to deploy 100,000 community healthcare workers, but we cannot do it without the countries. These people come from the countries. And so that's why we thought, let's hear about this initiative, also hear from a country that has benefited from this initiative. So if this is your first time and your country, from the presentation, your country hasn't benefited yet, if you know who it is we can write to in your country, just drop me an email. I've dropped my email on the chat box. Send me an email with the details of the person. If we've reached out to your country, it's not moving, just send an email. If there's a concern, if there are challenges, all you need to do is just send me an email and we'll follow it up. I'm the regional focal person for the CHW Technical Working Group. So once there's any question, anything on this initiative, just send me an email and we'll follow it up as Africa CDC to ensure that things move well and we really fight this COVID-19. So if there's any question, we're already 12 minutes past our time, but I think it's worth it. We've learned a lot today. So if there are any questions, any comments, any concerns, just quickly raise your hand or drop it in the chat box. I have a hand raised next to me. Chika, you can.
Okay, thank you, Dr. Portia, and thank you for the amazing work you guys, Zimbabwe has been doing. Really appreciate the good work. My question is on the success story slide. I saw something about CHWs as a proof. Could you please, Esme, can you take us to that part, please? So I would like to know, how do you share the CHWs to the community? Is it, I don't know, what medium do you use in sharing the CHWs, especially for those who are not, who are incommunicado, they are not really internet savvy. I'm so interested to know how that is being done at the community level. Thank you.
Okay, so here it says use of a CHWs to make communities change.
Okay, so thank you. So we, since the COVID-19 outbreak, we have a daily situation report on the national status, and we share that on email, but we also have put it on WhatsApp platforms And the volunteer community workers got a gadget, a phone, which is a little bit smart, so it can take WhatsApp, and they throw the daily CHWs there, or the weekly. There's a weekly compilation. We have trained, I deliberately targeted some disabled communities. We trained 4 blind people, 2 deaf ones, and about 11 who are physically challenged. They always have a way of going around, because some of them came to the training without any assistance, because we could only afford so many. And they have a way of getting somebody to either read to them or give them the information. But we found that the majority were actually literate, and they can make sense of the report to an extent that they've been using that to confirm to people that there is COVID. Look, this is what our report says.
Okay, so if I get you correctly, the smartphone is given to the community health care workers.
Sorry, I didn't get your comment.
I mean, the smartphone, who is handling the smartphone? Community health care workers.
Yes, so each on their package, each volunteer community worker gets a phone, and they use that phone to report on a weekly basis. Remember, you then have to report on the packed indicators to Africa CDC.
Yes.
So we knew that within the community, some people may have a phone, but it's not smart, or they may not even have a phone. So it was then going to give us a lot of challenges. We input that into the budget, and we were able to get a good device for under $50.
Okay, thank you, Dr. Pasha, but sorry, I am hammering on this for too long. I just want to understand, the community healthcare workers, they have the smartphone, so how do they pass the message across to the community? Like, it's like a feedback of what has been done. You know, the CHWs is like a feedback, and to inform the community.
Okay, I see. I see. So we produce this. We produce the CHWs centrally, and the situation report takes information from the health facilities. What the PACT program has enabled us to do is to not wait until events come to the health facility, because in a crisis and an outbreak, that's already too late. So now we are extending the reporting of alerts and events into the community. This is why we have trained the volunteer community worker to use a simple phone to report to us. But the situation report still captures information from our 1,800 health facilities that report on the weekly or our rapid disease notification system. So I hope that answers the question. So this is actually a feedback loop where we give that situation report to these volunteer community workers so that they have continual updates of what is happening countrywide. But they are deployed to work in their own community, close to their home.
Okay, thank you so much.
Thank you.
There are 2 questions for you on the chat. We'll just quickly take them and then we'll call it a day. A lot of people are already leaving. We're 18 minutes past. So Viskovic Chanda from Zambia says, good presentation. How do you go about sustained motivation other than job enablers? That is one question. And the second one is, thank you. This is Spider from Namibia. Thank you, Dr. Portia. I want to know if these were newly recruited community healthcare workers, or you trained already existent cadres within your Ministry of Health. How practical is it to just train already existent community healthcare workers and retrain with a trust on COVID-19 issues? And the third one is, how do you reach communities with poor network regions? Dr. Portia, the questions are for you.
Okay, so thank you very much, and very good, very pertinent questions. Yes, we have existing community-based cadres, you know, the community-based home care providers, and then the village health workers. we looked for community, we looked for specific communities, remember, you know, from the border areas, from the hotspots. So these were not previously trained. Maybe one or two could be a village health worker who came along. But there is under the national COVID response, there's also been the capacitation of those other cadres. These ones were fresh. And I think that there's already been a lot of motivation for them in terms of getting a gadget, getting a thermometer, and putting it to use and reporting. But the ministry is also looking to strengthen our health system. It had a lot of challenges over the years. So I think they will actually find their way into the system in terms of the community structures that are coming up to strengthen our primary health care and look at the universal health coverage. So we are not bound to keep them after the support is ended, but from the enthusiasm and reporting, the quality of reports, I think they are already motivated by what the program gave them, and they can actually use the capacitation to find their way into more productive or even improving their own circumstances. I think it's good enough.
Okay.
So the other question was on, now I've lost my chat box and my battery is quite low. Did I answer all the questions, Azine?
The last one is, how do you reach communities with poor network?
Yes. So we do have a few that have challenges reporting, but remember their reporting is once a week. So I don't know that we have had communities where there is no network at all. So we've not quite had that challenge. I'm sure they are finding a way of getting to a spot where they can get network and report. One of the challenges has been we're using the Rapid Pro platform, SMS reporting. And once we finish training end of November, the bulk of the group, we found that it was difficult for the
So we've lost Dr. Portia, and I think it's a good point to call it a day. It has been a very exciting conversation, yes, but we're more than 20 minutes past our time. And thank you everyone for joining us today. And like I said, people from Eswatini, Mozambique, Lesotho, Botswana, if you can write and tell us who we can reach in your countries to follow up the official communication sent through the embassies, that would be very helpful. And the countries, Malawi and Zambia, if there are any challenges, you can write to me and we'll figure it out how to move forward. So thank you everyone. We have, a lot of people have already left the call and it's understandable, but this is to say thank you everyone for your time, and this should be our last echo for this year. And we'll meet again in 2021. Have a nice day.
Happy New Year in advance.
And Happy New Year in advance. Yeah.
Thank you. Bye-bye.
Recordings and the slides will be shared tomorrow evening.